Conservar la calma y no correr, no gritar, no empujar.
Hola, buenos días a todos. Muy bien, muchas gracias. Estamos aquí hoy listos para arrancar el año académico del Instituto Nacional de Cardiología con esta primera sesión de los miércoles, sesión general. Y primero, el doctor Carlos Sierra, que está aquí, nuestro director, para poder dar inicio a esta sesión. Justamente porque arrancábamos el año, quisimos que fuera algo muy especial y corresponde a imagen cardiovascular a resonancia magnética, la organización de la sesión en esta ocasión. Y quisimos hacer algo especial y pues tenemos el honor de contar con la participación de la doctora Damini Day. La doctora Damini Day es una científica muy reconocida en lo que se refiere al desarrollo de la imagen cardiovascular, análisis cuantitativo, laboratorio montado, y donde es directora justamente de análisis de imagen cardiovascular avanzada. La doctora Day es además una reconocida científica en lo que se refiere a todo el análisis cuantitativo en resonancia magnética y tomografía. Y sería el mencionar los múltiples reconocimientos que ha obtenido la doctora. El más reciente ha sido el Stefan Agenbach. Este es un premio distinguido para aquellos que han desarrollado en particular una que se refiere al área de la tomografía. Esto lo recibió recientemente de nuestro profesor Stefan Agenbach. Entonces, vamos con la doctora Damini Day con un tema muy importante de la inteligencia artificial, en particular la tomografía y contexto cuando lo podemos aplicar a la clínica. Agradezco a la doctora Damini Day. Dear Damini, thank you so much for being here with us. We have you here. I said everyone that all the important things that you have done in the field, many years working in this area, especially in Cedars-Sinai. Thank you so much. Thank you for being such a good friend with all of us in this area. Thank you so much, Damini. So we are your lecture now, please, Damini.
Thank you. Thank you so much. I hope you can hear me. Thank you for the very kind introduction. Muchas gracias, querida Aloha. Buenos días, damas y caballeros. I wish my Spanish was good to do the whole lecture in Spanish, but actually I have to switch to English. So my apologies here. I'm gonna just share my screen. Here, hope you can hear and see this. Okay, so I'm going to talk to you about AI in cardiac CT, a little bit about how to use it today. And here are my disclosures. So, AI, the scope of AI in cardiac CT is already very prevalent, and you have probably used AI because it's actually in every aspect of the patient's path through the hospital, through patient selection and protocoling, through image acquisition, image reconstruction, improvement of image quality, and segmentation and quantification to extract features like left ventricular ejection fraction from echo or coronary plaque from coronary CT angiography, LVEF from CMR, and then also from nuclear cardiology, the perfusion deficit from the nuclear cardiology scans. But this is, I can say that this is obvious AI because it's actually already mainstream. You will not know when you use it because the vendors actually have embraced it. So to do to do these tasks. But the next steps are classification and reporting, and this is already also prevalent. And then the final step is prognostication and management, whether it's for the patient, whether it's medical therapy or surgical intervention. So can AI help clinicians? So I will give an example of coronary CT angiography. So this is actually an example of a scan acquired with the photon counting CT scanner. And you can see the extraordinary spatial resolution of the photon counting CT with stenosis, which are detected here also by AI. But the important thing is that the coronary CT angiography, whether it's with photon counting CT scanner or with 64 slice multi-detector, 64 multi-detector CT scanner, can actually also image coronary plaque. So this is an example. This is an artist rendering of a blood going through the vessel, and here is the lipid-rich plaque, which is in yellow, and it has actually ruptured the thin fibrous cap and caused a thrombosis here. In CTA, we can image these plaques, and the AI can really help clinicians in the sense that they can help quantify this plaque, and this is actually of huge interest today. So this is something that we have been also working on. I'm going to talk to you about the Scott-Hart trial. So this is a landmark trial in coronary CT angiography. So this is before there was AI, and the quantification of 1769 patients of the CTA arm of the Scott-Hart trial took many dedicated fellows multiple weeks to quantify. And in this, however, in this study, we could show that the low attenuation non-calcified plaque, which is the surrogate of the lipid core that you saw in the artist rendering, is the highest predictor of future heart attack. And this was outperforming cardiovascular risk factors, nominal stenosis severity, CT calcium scoring, and the total plaque burden. How can AI help here? So this is work from our lab, which has been published in the Lancet Digital Health. So this is test an AI or a deep learning algorithm, which was trained with expert readers annotation of plaque and run on several hundred cases. And you can see an excellent correlation with deep learning and expert readers with expert readers as well as invasive intravascular ultrasound with an excellent correlation and agreement of 95%. And what's the advantage is the time to do this analysis is improved several fold by AI. And then we also looked at whether this AI-enabled plaque quantification, does it actually help in heart attack prediction? So this is again evaluated in the Scott-Hart trial, and the total plaque volume, a high total plaque volume predicted future heart attack over 5 years, with even when adjusted for quantitative stenosis and the cardiovascular risk score. So one of the things that we have done is there's thresholds for attenuation thresholds for non-calcified plaque are affected by the contrast uptake in the coronary arteries, and the software AutoPlaque that is developed at Cedars-Sinai does correct for that. And so you can see here an excellent agreement with intravascular ultrasound, and some of the other studies using other software also have shown that with a similar agreement. So, I mean, those AI models, they have to be incorporated into clinical software. And so this is what we see increasingly. This is AutoPlaque software. Here, this is one patient from our hospital. And this patient had no symptoms, but a high coronary calcium score and underwent CTA. And you can see that this is non-obstructive atherosclerosis here. But the atherosclerosis, and the red is non-calcified plaque and yellow is calcified plaque, and this can be quantified over the entire coronary tree. So how will actually this be used? So we know that actually women have a lower plaque volume, so of all subtypes, total plaque, non-calcified, and calcified plaque, compared to a male patient of the same age. So this has to be adjusted for age and gender. So this is one of our studies which has been published by Dr. Miller in Circulation Cardiovascular Imaging, and it had a derivation sample where percentiles could be derived for men and women and adjusted for age here. So this a little bit like the coronary calcium scoring percentiles that we use for men and women. And here, so we also looked at the prediction of future heart attack. So the patients in the highest percentile, so greater than 75th percentile, were at highest risk of heart attack, followed by the patients in 50th to 75th percentile, and compared to the patients in the lowest risk percentile, which is less than 50%, 50th percentile. And this has also been published by others. So this is Zimas in JACC Cardiovascular Imaging, who developed also the coronary plaque nomograms using other software. Total plaque volume has been quantified in also the ischemia trial. So you know the ischemia trial is patients with significant ischemia, and this is patients greater than 3,700 patients who had coronary CT angiography in the ischemia trial. And the ischemia trial being an international study of comparable health effectiveness with medical and invasive approaches. And the enrollment criteria was moderate or severe ischemia and the presence of obstructive coronary artery disease. So even in this diseased population, so you can see that the total plaque volume is, the median value was 494, which is high. And in this disease population, the addition of quantitative plaque increased the prediction of cardiovascular death and MI, but modestly from clinical risk factors, with the AUC increase from 0.61 to 0.65. And here are the survival risk, the risk of heart attack, cardiovascular death and heart attack, which you see here with different stages of plaque. So at the lowest stage, less than 250, stage 2, and stage 3 with the highest amount of total plaque volume. So this is a very hot topic, and there's a lot of interest in this because this is actually coming to clinical practice. The Society of Cardiovascular CT has published this excellent practice guidelines for the standards of quantitative assessments by coronary CT angiography quantitative plaque. And here you see actually one LAD lesion that is quantified by several software which are in use. But one of the things to just remember that, software ideally should consider the effects of X-ray tube voltage, tube current, luminal contrast, noise, and reconstruction parameters on plaque output and lumen wall segmentation, and most currently do not at this time. So this is another example of photon counting CT scanner. Also, a significant arteriosclerosis in the proximal segment here, and these are several. So this is the coronary artery imaged without any overlays, and here are plaque overlays with several software which are currently in use, and you can see that the quantitative assessment is possible. So we also know that CTFFR is prevalent, is used clinically, and this also uses AI. So this is CTFFR using the Siemens prototype software. And here you can see kind of an overlay over the coronary tree, which looks at luminal CTFFR hemodynamic significance over the entire coronary tree with a map of the AI-derived CTFFR. So I'll give you one example from our hospital. So this is a patient, 71-year-old male patient who had a stenosis which was not severe, was about 69% with remodeled proximal plaque with low attenuation plaque and napkin ring sign that you see here. And actually the CTFFR using HeartFlow software was significant for this patient after this in the left anterior descending artery. But the patient in consultation with the referring physician was managed medically. And here you can see a new scan about 6 years later. So we have done a full analysis of the coronary arteries with plaque, with total non-calcified, calcified, and low density plaque here in over 6 years. And you can see a significant reduction of the non-calcified plaque because of medical therapy, and also as well some reduction of low density plaque. Another patient from our hospital. So this is a female patient. It's a mother of 3, shortness of breath and chest pain while mountain biking. And the symptoms were resolved on resting. So coronary CTA was performed and with AI-enabled plaque analysis using autoplaque software. So with it was not expected to see non-calcified and calcified plaque, but both were imaged by coronary CT angiography. So you can see here, and the LCX and the RCA had non-calcified plaque, and the RCA also had calcified plaque. And the total plaque volume percentile was high for this patient, 61, although the total plaque volume is quite low, 90 millimeter cubed. And statin therapy was initiated with healthier lifestyle, and there's no symptoms 1 year later with improved lipids. And you're asking, where's the repeat CTA? And there was not a repeat CTA because there's no need. There's no symptoms. So, okay. So I'll move a little bit away from the coronaries to opportunistic risk prediction by AI in the whole thorax. So this is incidental findings by AI in a very large registry of 24,401 patients. This is the NLST study. There's 15 features for 32 cardiac structures, which can be automatically segmented by AI quite well. You can see here, including coronary calcium. So what's the predictor of death? So some of the predictors you see here, coronary artery calcium is a strong predictor of death even when quantified from ungated chest CT. Then all the other different parameters from the different organs here. And so here, the demographic prediction was with the AUC of 0.65, which increased when imaging was added. And then finally, when imaging and demographic were added together, there's the highest prediction of death in this population. I'll just show one example from this study. So this is a patient who was imaged, and the esophageal parameters were the highest predictors came up to be the highest for this patient in particular. And so the patient actually had the outcome of death in 4 years later because of cancer of the esophagus. And that can be, this kind of imaging biomarkers can be automatically extracted from even ungated chest CT by AI and can help in better risk stratification for the patient. So I'll talk a little bit about this study, which is body composition with AI. So this is actually from the CT attenuation correction scans, which are acquired for every PET scan. So this is PET CT myocardial perfusion imaging, which is very well prevalent in Mexico City, and we are honored to have so much collaboration from Aloha and Dr. Eric Alexanderson, Dr. Aloha Miav and Dr. Eric Alexanderson there. So this is 10,000 patients in 3 sites with a median age of 68 years. And we could segment muscle, several adipose tissue depots, including subcutaneous, epicardial, visceral, and intramuscular fat, as well as bone with 3D body composition, and which strongly predicted mortality. So I'm just going to show you some examples from this case. So patients at low risk of death, and here's the imaging biomarker. So for skeletal muscle, if there's a high volume of skeletal muscle that is of low risk, and a low volume and low quality of skeletal muscle is at high risk of death. And so here also you see intramuscular adipose tissue. So if there's a lot of fat in the muscle, that is actually very bad for you. Think Kobe beef, that's very bad actually. So subcutaneous adipose tissue, so this is immediately under the skin. It could be high, but that's low risk. So that does not seem to matter as much as the adipose tissue depots that are inside. For example, also epicardial fat, which is a high amount of epicardial fat is a very high risk. And also visceral adipose tissue, so this is well known, is at high risk. Higher amounts of visceral adipose tissue is at high risk. And then lower bone density is high risk as well. So there's value creation through AI and cardiac imaging. So kind of like every step of the way, including image analysis, interpretation, reporting, and then finally prediction and planning of treatment. But while you're using AI, there's definitely these stages of grief. The first is denial. We don't need AI. Then there's anger. Why am I forced to use it? Finally, there's bargaining. Maybe it's just useful for some limited tasks. There's depression. It will take my job away. And then finally, there's a nirvana of acceptance as it helps physicians and patients. Thank you very much for your attention. I'd like to take I'm happy to take any questions.
Me for this wholesome lecture. It was great. So I have invited, I think it's very important because you talk about the AI in cardiovascular imaging. I think that's interesting. So for this, the clinical.
I think I'm not hearing the voice very well. Aloha. Maybe.
Oh, I'm sorry.
Yeah.
Can you listen to me now?
Yeah, that's better. That's better. Yeah.
Perfect. So thank you so much, Damini. So great lecture and discussion because you talk of thinking about the clinical part. So the chair clinical area, room area. Excellent specialist in cardiovascular, Dr. Angel, Dr. Sierra, of course, for the discussion, Damini.
Sorry, I'm having trouble. It's getting cut off a little bit, so my apologies.
Okay, let me check about the sound, Damini. Just a minute. Can you listen to me now, Damini?
Yeah, that's better. Much better, yeah.
We don't have problems with the sound. So I'm ready here for the questions, Damini.
Yes. So, what? Can you tell me the question one more time?
Okay, so we'll make the questions here. So if we have here a question, we have to do it in this here, please.
And very interesting talk. I wanted to ask you, but you have and many people working with you, but how do you start with this job?
Sorry. Can you repeat that one? I can't hear still. It just gets cut off very much. I'm sorry. I only heard that interesting and many people work with you. That's all.
Can you hear me then?
Yes. Now I can hear.
I'm telling that you show us the many data about jobs in which there but in our country, well, not only in Mexico, in all the countries that have enough money for investment, how can we start with artificial intelligence?
So how can it help? How can artificial intelligence help clinically? Is that what you were thinking? I'm sorry. The sound is really not good.
No, it's okay, Damini. So the thing is about the question is how we can start doing AI in the institutes, for example, when we don't have the investment to work it. But I mean, we have all the patients that we have a lot of disease. So how we can improve? Maybe working about machine learning. We can start. How do you think we can start this area?
Okay, yeah, I understand. So I think like you're already actually using AI because of all the vendors' software that you have, and hardware as well. So for example, when a patient comes in and there is a suggestion to use a certain KVP for CT acquisition, based on the patient's static image, like the scout images, so that's already an AI algorithm. So you're already using AI in several, and then when you're doing coronary calcium scoring, all the vendors have switched to AI-based coronary calcium scoring. So the AI does the scoring, comes up, and then you say, okay, this is coronary calcification and this is aortic calcification, so we don't include it. So the final validation is done by the expert reader, but the AI really helps in the analysis and is very fast because it's already the algorithm is incorporated in the vendor's software. So I think that this is, I think, the way that AI is going to be used in the immediate future, because of regulatory and other issues, is that the doctor is always in the loop and has to say, okay, yes or no, validate, and this is okay to include in the patient report or not okay to include in the patient report. So so that this is like this, that the doctor is always in the loop. I hope that kind of answers your question.
Yes, but thank you. But I was thinking more in, we are using software that you develop, but sometimes there is not enough Latin or, for instance, Mexican people in which we can translate the numbers for our population.
Yes, that's a very good point, and of course that has to improve. So we need certainly data from across the world. Right now, there's like a really lack of the right data in the AI algorithms, right? That's kind of is the problem. It's for every application. This is a problem, and this has to improve.
Thank you.
We have the next question, Damini.
Hello, doctor. Thank you for the conference. It was very interesting because I noticed that in the beginning we think that AI can help with imaging, maybe with the interpretation, but now we can see that maybe we can do more about the imaging. And it was very interesting what talk about you about volumetric body composition with AI. Because in the past we think that maybe visceral AT or epicardial AT can predict something, but we can do it very well with the visual evaluation. What do you think about that for prediction risk? What is the moment that we are now with these other findings that we can have, not only with cardiac imaging, maybe with all the CT, all the thoracic CT that we can do in these patients?
Yes, I think that's a great question. So I think the thing is that the AI here is a tool because it's fully quantitative, and it can tell you, okay, compared to what's the median or the threshold for in this population, it is high. So it can in like 1 second it runs in the background, and when you open the study, it can tell you, okay, this patient has a higher epicardial fat than kind of what is in this population and is at higher risk. Visually, I think you would have to go through multiple slices and try to kind of interpret how much is it, and it's a little difficult. But of course, you can say, okay, this patient has a large amount of epicardial fat and visceral fat. The other thing is that these are individual biomarkers, and they can help, but they're just one biomarker. And the other use of AI, which I did not show for this talk, is that AI can actually help you integrate multiple biomarkers and give you a prediction.
So maybe not only the epicardial fat, maybe sometimes when you have low skeletal muscle and high epicardial fat, maybe is a risk factor for something for cardiovascular risk. And this is something that we don't report in this moment, and we don't know in all the CT, or we don't report in the cardiovascular imaging. Another question that I have, I see in your slides that maybe it's a role about AI in the acquisition on CT or cardiovascular CT. Are you doing something about to improve acquisition of the CT with AI in this moment?
Sorry, what was the question?
The acquisition, the CT acquisition.
Acquisition? You mean acquisition, right? Yeah. So this is, it's not exactly our group's expertise, but the vendors actually have done a lot with CT acquisition, and you will see kind of like more improved protocols, so AI is used in the background. And there are several kind of very good work on actual on improving the noise in the images, like denoising, for example, to try to improve, and then to maybe also resolve minor artifacts even after the acquisition. So yeah, absolutely. So this is one of the really hot topics of the field. But it's actually kind of the first step is done by the vendors extensively for image acquisition. And then the second step, it could be done for improvement of the images after acquisition.
Thank you, doctor, and congratulations again.
Thank you.
Perfect, Damini. So now here we have the other questions. Eduardo?
So thank you, Dr. Day, for the amazing talk. This is Eduardo Arias from Interventional Cardiology Department. So I saw that you published recently an American Heart Association statement about the value of integrating artificial intelligence in cardiovascular practice. So I wanted to ask you, in your practice or in your experience, how has the use of AI translated in doing less unnecessary procedures, or has it been beneficial to save money in terms of hospital days, waiting lists, and things like that? Because I think part of the important thing of using AI is probably to keep the patients away from the hospital if necessary, unless it's really necessary to bring them into hospital. So I wanted to ask you that first question. So the value, the added value of having an AI program. And the second one, the room here is packed with fellows and residents. So one of the different conferences, they say that one of the major risks of AI in cardiovascular medicine is de-skilling, the risk of de-skilling with clinical practice and with decision-making processes and everything. So how do you cope with this risk of de-skilling with people that are training in interpreting CT scans or making decisions, not to rely just what the artificial intelligence says?
Okay, so that's a great question. So I'll answer the first one first. So I think I could give the example of CTFFR, which is done a lot in our institution, and the algorithm that's most used is AI-based, and it's by HeartFlow, and that is kind of either that or AI-based nuclear cardiology is required before cath. So, so that already this is kind of, we have a decrease in cath and we have decrease in diagnostic catheterization. So this is kind of across, I think, all sites really. But I will say that that has not decreased the load, because there's more and more people who still need the treatment, and the volume of CTA particularly is increasing very, very rapidly. So I think while per patient time has been helped by AI, the total volume has not gone down. Does that answer? I mean, maybe it's similar in your hospital as well.
Yeah, it makes sense.
Yeah. And the second one is for fellows. So it's very important to know the standard reading of the scans. Without AI. So I am not sure what's the right answer, because this is like a really evolving topic, and I have not seen guidelines, but I think maybe a stepwise approach could be good. So the fellows, when they start out, they read the standard way, CTs and CMRs, with minimal AI. And then in the kind of the last part of their fellowship, they also know what the state of the art is in AI. But I think it's very important to know how to read the scans based on the guidelines. And, that's always needed, because sometimes if the AI is wrong, the doctor has to be the corrector, right? And the AI will improve, but it can be wrong. So we need to do this. Yeah,
definitely. It's more like a co-pilot, no? Like a co-pilot.
Yes, it's like a co-pilot, right? So co-pilot is right maybe 95% of the time and wrong 5%. But for those 5% of the patients, they need to have good treatment, right? They need to have a good diagnosis.
Excellent. Thank you very much.
Eric, now for questions. Thank you.
Hi, Damini, this is Eric. Nice to meet you.
Hi, Eric. How are you? Yeah,
Hi,
nice to see you.
how are you?
Good.
I want to do a very, very short history of experience with artificial intelligence in cardiology. When I was training at your site in 1994, 95, I was in contact with artificial intelligence used in nuclear cardiology, and it was great because it changed during all the world the way to visualize the information of the nuclear studies. After being in contact with you and Piotr, we get experience to calculate flow using the software for cardiac PET, and also you gave us an initial version of the autoplaque program that I gave to the CT department to work in the coronary arteries. Also, we get a very nice experience now getting multiple abstracts and papers about refined PET cardiac CT project, and this is great. My question is, I visualize the importance of the artificial intelligence since last century because it was in the 1994, 95, etc. Could it be possible, and also to help the idea of Dr. Gabriela, that we can share some kind of research with your group and you facilitate us part of your software to use by research with the information of the patients we have in our institute, in the MR, in the CT, and in the nuclear department? That would be great. Continuous working together as the last 20, 25 years to get more experience. We learn before you are able to get the softwares by buying, because sometimes the economic problems in Latin America don't allow to get this information as soon as we get, and we like to have it. Is that possible?
Yes, absolutely. I think we have a wonderful research collaborations with you, and I know for Refined PET, this is a huge registry, and a lot of very interesting investigations are ongoing. And we really value your collaboration and your amazing data. So, absolutely possible. We should talk. And yeah, it's absolutely possible. Our expertise is with CT and nuclear more for our immediate team, not so much CMR. For CMR, we use like a Circle cardiovascular imaging software, which also uses AI, but that's already a vendor software. Yeah.
Okay.
Yeah, absolutely. Agree.
Perfect.
Yes.
That will be great for us because it's a way to have the most advanced information of software to apply in our patients, and that will be very helpful to take decisions, major decisions in our population, to choose the best therapy for them, and of course to be part of this very important circle you have about research. That will be great. We need to talk about it. It's a way to only to push the question there. Thank you so much. I appreciate it.
Absolutely. Yes.
See
Thank you.
soon.
Thank you.
Thank
Yeah.
you.
See you soon. Yeah.
Thank you.
Thank you, Damini. And now we have Dr. Sierra.
Hello, thank you, Dr. Denny. It's a great pleasure to have you here, and also thank you for your amazing lecture. You have to know that I'm really convinced that AI is an ally, so we have to embrace it. Not otherwise, we have to apply it in clinical practice or in the clinical arena. So based on that, I have two questions for you, if I may. One is we have to translate it into clinical practice. So how do you think of there's clinical evidence of how the volumetric plaque or plaque volume should be have the clinical modifying by the optimal medical therapy? If there's any evidence of how this optimal medical therapy could modify the volume, the plaque volume, and how there's a clinical risk based on that. And the second question, we have robust evidence that supports, based on confirmed trial, that the plaque volume have the clinical implication in terms of MACE by phenotyping these plaques. So how far do you think we are to applying this observation and prognostic results in the clinical practice? How do we can translate into CBOT trials of how far do we are to apply intelligence, artificial intelligence in TBOT trials or interventional studies?
Okay, so this is great questions, and I'll maybe give you one example, which is in our hospital. This is the EVOLVE study. I'll try to, I didn't show this because of lack of time, but this is a prospective study at our hospital. So these were patients with severe arthrosclerosis who were initiated on evolocumab. So this is a PCSK9 inhibitor, and so they were imaged at the beginning with CTA as well as sodium fluoride PET, and imaged 1.5 years, so 18 months later, with the same protocol. So it's a small study. It's been published in JACC Cardiovascular Imaging. So we had a reduction. You can see this, and this is what we also see with statins, with intensive statin therapy, or in general with statin therapy, is that there's a decrease in non-calcified plaque volume. And sorry, one second, low density non-calcified plaque volume and an increase in calcified plaque volume. So there's plaque regression and plaque stabilization. As well, for this particular study, sodium fluoride, the cardiac metabolic activity, so this is over the whole coronary tree. It's like a little bit like the SUVs over the whole coronary tree. Coronary microcalcification activity was significantly decreased with therapy. So these kind of studies are coming along, and actually I have to say that one of the ways it's used at Cedars-Sinai is with serial assessment of patients, which is kind of the toughest thing, but also the most exciting thing, So, so more data is coming. But yeah, so that's one of the changes that we observe in plaque composition with therapy. And I think, did that answer your question? There was another part.
The second question was, there's the evidence that supports the prognostic implication of AI in coronary plaque phenotyping. Okay. But how far do we are in applying this in interventional studies, in CBOT trials, in clinical interventional? How far do we are?
So we are at the very start of applying plaque to clinical intervention. We have, most of our studies have been more in prevention. So they're with therapy rather than intervention. But for example, we have published a lot on like a ischemia risk score based on stenosis and plaque, because AI can actually combine them and give you a high risk of ischemia. So it can help in therapy. There's others who have published and looked at particularly the calcification density. And that's very important to know before the intervention. So, but I will say that the results, so there's the P4 trial, for example, which enrolled the last patient, I think, recently. So the results are coming. We are in the kind of the infancy of seeing AI-enabled plaque in intervention.
Okay, thank you.
Thank you so much, Damini. I think it has been a wholesome discussion, so thank you so much for your time. And I would like to close the session if you can tell us your thoughts about what will happen with AI in cardiovascular imaging, cardiac CT especially, talking about this new technology that what we had seen, it's very impressive about the photon counting, how it's going to, what are your thoughts of how it's going to improve all the apply of the AI in cardiovascular CT?
Yeah, so that's a great question. And I showed, I think, this image from the photon counting CT. So the photon counting CT can only help because of it's a paradigm change in the hardware of CT, and it has much higher resolution. So the standard, so these are the series that where the standard clinical read is done, and you can see that that can already be quantified by AI-enabled plaque analysis software. But there's also another aspect, which is spectral analysis of photon counting CT, so the spectral acquisition, and how that actually will, how can that help in plaque characterization? That's not yet known. We know that the fixed thresholds that we use, that some of the vendors use for plaque analysis, do not work with those spectral images. So, so that is so data is coming with respect to that as well. But of course we need like invasive validation. So, it's challenging, but it will be coming.
Perfect, Damini. Well, Damini, so we are here at the end of your participation, and we are very glad, very thanks about all the generous that you are always with all of us, and thank you so much. And I think this is a magnificent session to start the year, and I hope it will encourage everyone, all the residents, all the young people, and of course, all that we are working very hard in our institutions. Thank you so much, Damini. So I think a big applause now.
Thank you so much. Thank you for inviting me, and thank you for a most exciting discussion.
Thank you so much, Damini. So we'll close the part with Dr. Damini Day. Y me gustaría cerrar esta sesión ahora en español. Y me gustaría, creo que fue magnífico muy agradecidos de que nos hayan asignado esta primera sesión del 2026. Y creo que qué mejor que empezar justamente con la participación de la profesora Damini Day, que es tan importante en el área de imagen cardíaca, con todos los desarrollos que tiene los últimos 30 años trabajando de manera muy fuerte. Agradecer, creo que fue muy importante, y agradezco la participación de nuestros expertos. Y me gustaría dejar muy claro, creo que esto es algo muy bueno para empezar el año, y justamente nos habla de cuál es el papel de los institutos nacionales de salud de nuestro país, y es justamente hablar de este tema, es decir, hablar de medicina avanzada. Son centros de alta especialidad, ese es nuestro objetivo principal, el de trabajar y desarrollar justamente estos aspectos. Una participación muy importante fue la de la doctora Gabriela Meléndez, en donde ¿qué hacemos nosotros para poder empezar a trabajar con inteligencia artificial? Tenemos absolutamente todo, tenemos los expertos, tenemos los equipos, y algo muy importante es que tenemos los pacientes, tenemos una población muy enferma que son una gran parte de los datos que se requieren para el desarrollo de toda esta tecnología. Entonces, creo que la parte de colaboración, no tenemos que inventar el hilo negro, es buscar justamente estos convenios colaborativos con grandes centros que ya lo desarrollan. Y agradezco a todos, y justamente que quede esa idea durante todo el año, que este es el camino, los objetivos que debemos de seguir, el seguir medicina de alta especialidad en nuestros centros, y en particular decirle a los jóvenes que, bueno, ustedes ya nos platicarán dentro de 20 años cómo se está desarrollando esta área de la medicina. Muchas gracias. Gracias al doctor Sierra.